Hello friends, this is Nishan presenting to you an interesting topic, that is acid-base disorders. We come across a lot of questions on acid-base disorders in various competitive exams, be it NEET, be it USMLE, be it any other competitive exam, and many of us face difficulties in approaching those questions. That is why I have decided to make this video. So without any delay, let's get started. These are my references for this video. Second and third, that is Paul Marino's ICU book and Washington Manual of Critical Care, are two really good books to read this topic from, and first and fourth are two really good papers to read this topic in detail. So how important are acid-base disorders or acid-base balance for life and for exam? I would like to describe it by using the adjectives very important. So you are very likely to see multiple questions on your USMLE steps or on your NEET exam from this topic, and perhaps they are very important for life because small changes in hydrogen ion concentrations can alter the functions of various enzymes, various ion channels to a great extent. That is why there is a range of pH that is compatible with life, that is 6.8 to 7.8. While looking at the acid-base disorders, we are mainly going to look at four values. Number one is pH, number two is PCO2, that is partial pressure of carbon dioxide in the arterial blood, then bicarb concentration, and the anion gap. So the normal range of pH is from 7.38 to 7.42, with the average value for question purposes being 7.4. Normal range of PCO2 is 38 to 42 millimeters of mercury, with the average value for question purposes being 40. The normal range of bicarb is between 22 to 26, with average value being 24. Anion gap, however, varies with laboratories from place to place, but I have taken this reference range from the Paul Marino's ICU book. It says 8 to 16. However, for exam purposes or for question solving purposes, you can take the value of anion gap as normal value of anion gap as 12. So what is the most basic rule for approaching any acid-base problem? Number one is you first look at pH. So if the pH is less than 7.38, the primary disorder is acidosis. If the pH is more than 7.42, the primary disorder is alkalosis. It can be respiratory, it can be metabolic, but this is how you first approach the acid-base problem. If pH is normal, it can be a normal ABG or it can be a mixed acid-base disorder. I will talk about them in the subsequent slides, but for now just remember that if the pH is normal, you should look at PCO2, and the direction of change of PCO2 determines what is the primary disorder. So let's see how to approach it. So looking at stepwise approach to acid-base problems. Number one is you should look at pH and PCO2. Mind you, identifying primary disorders is not limited to identifying whether it's acidosis or alkalosis. You also have to identify whether it's respiratory or metabolic. So if you see that pH and PCO2 both are normal, it means that there is no acid-base disorder. If one of them is abnormal, however, there is an acid-base disorder. That's how you see if there is an acid-base disorder or not. So what you can do is, once you have seen those and you have seen that one of them is abnormal, you should see whether the direction of change of pH and PCO2. If pH and PCO2 change in same direction, that is if pH increases and PCO2 increases, or if pH decreases and PCO2 decreases, the primary disorder is metabolic. If pH and PCO2 change in opposite direction, that is if pH increases, PCO2 decreases, or pH decreases and PCO2 increases, the primary disorder is respiratory. How you can remember this is respiratory has RE as first two letters, and RE are also the first two letters of the word reverse. So just say for an example, if the pH becomes 7.23 and PCO2 is 60. So pH has decreased and PCO2 has increased, which tells you that it's a respiratory disorder. And looking at the pH, you can safely say that it is a respiratory acidosis. Then again, if pH is 7.5 and PCO2 is 50. It tells you that pH has increased and PCO2 has increased as well, which basically means that it's a metabolic disorder. This tells you that it's a alkalosis, so it's a metabolic alkalosis, and the change in PCO2 is basically a compensation for the metabolic alkalosis, the respiratory compensation for metabolic alkalosis. So let's look at few more examples. So we have a 49-year-old male with following ABG, pH of 7.32 and PCO2 of 50. So the pH has decreased as compared to normal value and the PCO2 has increased as compared to normal value, which tells you that it's a respiratory disorder. Then you can easily say that pH is less than 7.38, which tells you that it's an acidosis. So the primary disorder becomes respiratory acidosis, which is what I have written in this explanation. Let's look at one more example, a 72-year-old male with following ABG, pH of 7.30 and PCO2 of 29. So pH is less than 7.38, which tells you that it's an acidosis, and PCO2 is basically less than 40, which tells you the direction of both of them have decreased, so it tells you that it's a metabolic disorder. So pH and PCO2 changing in same direction, it's a metabolic acidosis. I want to talk about an interesting and important concept called as anion gap. So anion gap is basically number of unmeasured anions in the blood. How we calculate number of unmeasured anions? We don't use any instruments to measure them. We just measure the ions that we can easily measure, and then we do some mathematics and we estimate the number of unmeasured anions. So we know that at the baseline, positive charge in the blood is equal to negative charge. That is why blood is electrically neutral, which means that sodium plus potassium plus unmeasured cations is equal to chloride plus bicarb plus unmeasured anions. So this is what we have to calculate. So how we will calculate is basically unmeasured anions is equal to sodium plus potassium plus unmeasured cations minus chloride minus bicarb. The values of potassium and unmeasured cations are often very low as compared to sodium and chloride and bicarb values, so we just tend to ignore them and we calculate the anion gap, that is unmeasured anions, as sodium minus chloride minus bicarb. This is the formula of calculating unmeasured anions, also called as anion gap. So this is just what I have explained in the previous slide. Anion gap is calculated by this formula, and it tells us about number of unmeasured anions and is useful in finding etiology of metabolic acidosis. So usefulness of anion gap. Anion gap is useful in classifying mainly metabolic acidosis, and sometimes it acts as a diagnostic aid in diagnosis of lithium toxicity. So let's see how. The normal range of anion gap is 8 to 16. So whenever it is more than 16, we'll call it high anion gap. So high anion gap basically is anion gap of more than 16 and is seen in high anion gap metabolic acidosis. Normal anion gap can be seen in normal people or in normal anion gap metabolic acidosis. Lower anion gap, however, slightly unusual occurrence or slightly rare occurrence, can be seen in lithium toxicity and hypercalcemia. So expected values of PCO2 and bicarb in metabolic and respiratory disorders respectively. That is what I want to talk about, is expected compensation. It is very easy to understand that if there is a metabolic disorder, the compensation will occur by respiratory means, and if there is a respiratory disorder, the compensation will occur by metabolic means. So the compensation by respiratory means is either hyperventilation or hypoventilation. And compensation by metabolic means is basically either increased absorption of bicarb in kidney or decreased absorption of bicarb in kidney. So let's look at few specifics. In metabolic disorders, we expect compensation by increase or decrease in ventilation. We all know that carbon dioxide, when combining with water, it forms carbonic acid, which is a weak acid. So in metabolic acidosis, we want to get rid of acid. Our body already has acid and we want to get rid of that. So what we will do is we will wash out the carbon dioxide by means of increased ventilation or by hyperventilation. That will result into a decrease in partial pressure of carbon dioxide or decrease in PCO2. Hence, in this case, you will see a PCO2 which will be of less than 40. Mind you, this is in isolated metabolic acidosis. Then in metabolic alkalosis, we want to preserve acid as carbon dioxide is an acid. It basically forms a weak acid on combining with water. So we will decrease the ventilation, that is we will cause hypoventilation, and that will result into PCO2 that will be increased. So PCO2 will be more than 40 in isolated metabolic alkalosis. So in respiratory disorders, we expect compensation by decrease or increase in bicarb excretion. In respiratory acidosis, we already have acid, we want to preserve base. So what we will do is we will decrease the excretion of bicarb. That will result into preservation of bicarb and as a result bicarb levels in the blood will increase. So you will often see that bicarb levels will be more than 24 in respiratory acidosis. In respiratory alkalosis, however, we want to get rid of base because we already have base. We want to get rid of base. So we increase the excretion of bicarb. As a result, bicarb concentration in the blood will decrease. So bicarb concentration in acute isolated respiratory alkalosis will often be less than 24. Now it is very important to remember that kidney takes some time to come into action. So that is why these disorders, they are classified into acute and chronic. So respiratory acidosis is classified into acute respiratory acidosis and chronic respiratory acidosis. The compensation is different for both of them, as you will see in the next few slides. And respiratory alkalosis is again classified into acute and chronic, and the compensation is different for both of them. So how much bicarb will increase or decrease will depend on the chronicity of disease and the severity of the disease. My next few slides might seem somewhat complicated or tough to begin with, but trust me, if you follow these steps, it is very hard to get a question wrong on ABG. So once you practice, it becomes easy. So kindly follow me in the next few slides. So compensation. In metabolic acidosis, we have a formula called as Winter's formula that gives us the expected compensation of carbon dioxide or the expected PCO2 level, and it is calculated by 1.5 times bicarb concentration plus 8 plus minus 2. So it gives us a range. Let's see if bicarb is 8. So 1.5 times 8, bicarb of 8 means that's a severe metabolic acidosis. So 1.5 times 8 plus minus 2. So it gives us the value of 12 plus 8 plus minus 2. So it gives us value of 20 plus minus 2, that is 18 to 22. So this gives us expected PCO2 range. Then in metabolic alkalosis, for every 1 milliequivalent rise in bicarb, the PCO2 rises by 0.7 millimeters of mercury. Then this table is very important for respiratory disorder, respiratory acidosis and alkalosis, and on this side of the table is acute and chronic. For every 10 millimeters of mercury rise in partial pressure of carbon dioxide, the bicarb rises by 1 milliequivalent in acute respiratory acidosis. Likewise, for chronic respiratory acidosis, for every 10 millimeters of mercury rise in PCO2, the bicarb rises by 4 milliequivalents. Similarly, in respiratory alkalosis, in acute respiratory alkalosis, for every 10 millimeters of mercury fall in PCO2, the bicarb will fall by 2 milliequivalents. And in chronic respiratory alkalosis, for every 10 millimeters of mercury fall in PCO2, the bicarb will fall by 4. See, it's very easy to understand. If you think about it, respiratory acidosis means CO2 will be preserved. That is, CO2 will be more. So that means more acid is there. So how we can counter it is by preserving base. So we increase the value of bicarb as a compensatory mechanism. And in acute respiratory alkalosis, CO2 has decreased. We don't need any more base. So we will increase the excretion of bicarb, and bicarb level as a result will fall. I want you to take a screenshot and perhaps take a printout of this paper, as it is going to be very important in the next few slides. Always remember that compensation, it tries to correct the disorder, but it is never able to correct the disorder fully. So pH will never normalize because of compensation. If you have a metabolic acidosis and you compensate by increasing the ventilation, so pH will never be 7.4 in state of compensation. If you see a pH of 7.4 in presence of bicarb of say 18, it means that there is something else going on, because the disease is never, the pH is never fully corrected. So how to go about it? Let's see. We calculate the expected compensation by the formulas that have been written in the slide that was 2 slides back, and we get the value of expected PCO2 and expected HCO3 depending on what is the primary disorder. And to look at the values of measured PCO2 and measured HCO3, you just have to look at the ABG. So you have to do a little bit of calculation, and you have to see if the measured PCO2, if it's equal or if it's more or it's less than expected PCO2, and if the measured bicarb is equal, more or less than the expected bicarb. So if just imagine it like this: if measured PCO2 is more than expected, which means that the body is retaining carbon dioxide. In what disorder do we retain carbon dioxide? Yes, that's correct. It is respiratory acidosis. Then, if the measured PCO2 is less than expected PCO2, that is, let's say the body is clearing more carbon dioxide. So when the body clears more carbon dioxide, it results into what? Respiratory alkalosis. If the measured bicarb is more than expected bicarb, it means that body is retaining more bicarb, and guess in which disease we retain more bicarb? Yes, metabolic alkalosis. And likewise, in which disease do we lose more bicarb? Yep, metabolic acidosis. So this is a very important slide. So I want you to take a screenshot of this as well. Now that we have built a strong base, let's do a few examples. So in this case, we have a 52-year-old sedentary male who took a 15 hours flight, coming in with acute onset of shortness of breath. Cardiovascular and respiratory examinations are pretty much normal. Examination of extremities show unilateral pitting edema of the left lower limb, and arterial blood gas shows pH of 7.48, PCO2 of 30, bicarb of 22, and partial pressure of oxygen of 75. So what is the clinical diagnosis and which acid-base disorder is present? So I want you to pause for a minute and just solve it on your own, then we can solve it together. Alright, so the clinical diagnosis, I'm sure most of you might have guessed it right. It's basically acute pulmonary embolism. Most likely it's acute pulmonary embolism. Now looking at the acid-base disorder, let's see what we come up with. So the pH in this given case is 7.48. So 7.48 is more than 7.42. So the pH has increased, which tells us that the disorder is alkalosis. Then in this case, we saw that PCO2 was 30, which is less than 40, which is the normal range of normal value for calculation purposes of PCO2. That is, it has decreased, which tells us that both of them have changed into different directions, to opposite directions. And when the pH and PCO2 they change in opposite direction, the disorder is respiratory. So in this case, the respiratory disorder becomes respiratory alkalosis. As the presentation is of 3 hours, the disorder becomes acute respiratory alkalosis. Now in acute respiratory alkalosis, we know that every 10 millimeters of mercury fall in PCO2, the bicarb falls by 2. So here the PCO2 has fallen by 10. So that is why the bicarb should be falling by 2. So for calculation purposes, we know that normal value of bicarb, we take it as 24. So 24 minus 2 is 22, which is appropriate compensation. So the disorder is isolated respiratory alkalosis. Let's look at one more example to get some more clarity on this. So here we have a 78-year-old female who has been admitted to the ICU, and her ABG on the rounds was found to be like this: pH of 7.18, PCO2 of 28, and bicarb of 8. So our task is to identify the primary acid-base disorder and comment on the presence of mixed acid-base disorder should there be any. So I will again take a 1 second pause so that you guys can pause and solve it on your own. Then we'll solve it together. So in this case, pH is 7.18 and 7.18 is definitely less than 7.38, which tells us that the disorder is acidosis. The pH has decreased. So in this case, we look at PCO2. The value of PCO2 is 28, which is less than 40, which tells us that the PCO2 also has decreased. They change in same direction, the pH also decreases and the PCO2 also decreases, which tells us that it's a metabolic disorder. So the primary disorder automatically becomes metabolic acidosis. For metabolic acidosis, we have a Winter's formula to calculate the expected value of PCO2. You might want to have a look at this formula again. So expected PCO2 is basically 1.5 times bicarb concentrations plus 8 plus minus 2. This gives us a range. So x to y is the range that we will get. So PCO2 becomes, in this case bicarb is 8, so it becomes 1.5 times 8 is 12 plus 8 plus minus 2. This plus minus 2 is because it gives us a range. So when we calculate, it comes out to be 18 to 22. So in the given example, PCO2 is 28, which is more than 18 to 22, which tells us that the body is retaining more carbon dioxide than it should be retaining. So there is a coexisting respiratory acidosis as well. So the primary disorder primary is metabolic acidosis, plus there is a coexisting respiratory acidosis. It's a tough topic and requires a lot of practice. I would recommend you guys to go through multiple ABGs, solve them and cross check your answers. I will be making another video soon in which I solve multiple examples. So I want to mention 4 very special people. Number 1, Dr. Christian Ascoli. Number 2, Dr. Kevin Haas. The people who taught me how to analyze the ABG and how to approach the ABG. Then 2 very close friends of mine, Dr. Pranav Patil and Dr. Aditya Rulat, whose inputs have been invaluable in improving this presentation. Thank you for watching my video. If you liked the video, please like, share and subscribe. If you have any questions, concerns or doubt, feel free to reach me at love.intmed@gmail.com. Again, thank you so much.